this conference. My name is Sara Ahmad. I am a global health professional. I have had over a decade of years of experience in tuberculosis case detection, particularly in child TB. And my research thesis for my master's program, which have graduated from in last May, was based on finding barriers and facilitators to timely diagnosis of tuberculosis in children and adolescents in Karachi, Pakistan. Karachi is where I have been based in. I'm born and bred in Karachi, and I've kind of worked in Karachi for most of my public health career. So I kind of did my research thesis there as well, since I was familiar with this setting. I will go quickly because there's a lot to say on this topic, but I will try to make it brief. So, firstly, the first time I worked on child TB was when I joined a program in 2015. And in this program, we went to rural Pakistan where there were very few children being found with TB, even though there was a facility which had doctors and they were trained on detecting TB. So once we trained those doctors and we brought this intervention in, our numbers of child TB went really high in a very short period of time. And we detected 1,417 children with TB in this amount of time, which was like almost a year and a half. So why at this particular finding in this project, even though it was a very small project, but it led us to wonder why is it that doctors are not finding TB in children, even though they are finding them in adults. So there are a few reasons for that. And first, a few of them are that TB is very hard to find in children because children cannot expectorate sputum easily. So they tend to struggle with, doctors tend to struggle to find bacteria in the tests that they order for children. Even if the tests are not ordered, the symptoms are non-specific and they're confused with other similar diseases like typhoid and malaria. And so doctors tend to go more toward those diseases than TB. It's not the first diagnosis that they go toward. And thirdly, it is also that children themselves are very hesitant to come to hospitals. Parents tend to become very reluctant to know that, oh, there can be TB in a child. Usually, there is no such awareness amongst parents as well. So that's why we are finding more and more children that die of TB. These are a few global stats that we can look at. For some of them are telling us that in spite of being curable and preventable, TB remains a top killer of children younger than 5 years globally. And also, one of the more rare facts is that TB is also one of the top three causes of death among adolescents, which is an older age group in children, usually 10 to 18 years of age or 10 to 17 years of age. Now, a little background on Karachi. Karachi is a very highly populated city in the world. It's the 12th largest. It is also like the entire country has like is very poor because it lives 70% of the population lives below the poverty line. And because it's so poor and it's very crowded as well. So these are the factors that affect the spread of TB in a setting like that. And if we go into the background of the country and why and how we came to this, very briefly, the country came into being in 1947, where was already since due to British colonization, struck with poverty because of several reasons before 1947. After 1947, it began with a very weak health infrastructure. And because it was bereft with wars after that, like 3 wars happened, as well as there was an influx of refugees across the Afghan border, it kind of stayed in that state, even though initially there was hope, but gradually we could not grow our health infrastructure. Also, there was the pandemic. There have been several disastrous floods and earthquakes and political instability, which has further led to the fact that the health sector has not improved in the country. Now, coming to the social determinants, every disease has a social determinant as well, like a few social determinants that affect the fact that why is it still prevalent. And by social determinants, we mean that what is the in the environment of the patient that is kind of making this disease not go away. And in case of TB, we can look at poverty and malnutrition as the main social determinants, because these are the most rampant social determinants wherever there are high burden TB countries. So these are the common determinants that we can see across the board. In the setting of Karachi itself, we went to the Indus Hospital, which is one of the major hospitals in the country, which is also private hospital. And TB clinic there sees around 150 200 children with TB every month. These are the children that are diagnosed with TB. Otherwise, it is looking at a big number of patients because it offers free of cost healthcare. A little context on general physicians. When I use the term general physicians from here onwards, these are the doctors who are sitting as in primary care, private clinics, and these doctors sit in very urban but low income areas. So they usually become the first line of contact for patients when anybody falls sick in the family because they are very close to their homes. And also, they are not affiliated with any hospitals. So they're not trained by any hospital. There's no regulatory body looking at their work. There's nobody checking on who they are treating and how they are treating them. Also, I will give a little detail about the delays that I calculated in this research because these are very important to know. There were 3 delays that we calculated from the time a child fell sick to the time they made first contact with the healthcare provider. Now, this can be anyone. It can be a spiritual healer. It can be a midwife coming to the patient's home. But as long as it's a contact the healthcare provider, that first time taken is the delay. That's the first delay. The second delay is when they come to the healthcare provider, but then there comes a long time till they're actually diagnosed with TB, and that's the second delay. And the third delay is from the time they were diagnosed with TB till the time they were started on treatment. This is also called the pre-treatment delay. Now, this is very detailed, but just to make it simple, we first of all, we categorized into two age groups for children. We took 0 to 9, 8 years of age, and adolescents, we took 10 to under 18 years of age, because this is how usually studies are, this is how they take the age groups. And also we did purposeful sampling to make sure that when we took surveys and interviews, we took them from each age group. So we get a more representative sample for the research and there's less bias involved. Um, so what we did was that first we went to 800 caregivers of the children who were being diagnosed with TB. And we made sure that they were surveyed. And now what do we mean by surveyed? We just asked them a few questions based on how long it took them to go to each healthcare provider from one person to another, and that's it. That quantitatively, we took them in a survey from 100 people. Then we also did qualitative interviews. This was a very different thing for me because this is the first time I did qualitative research, which is very rarely some rare training that we receive. And this is the first time we did that. So we took interviews from these 100 caregivers. We went to 40 of them, and we also took interviews of them where we actually asked them their experience and how they were, where they went, what did they do, how long did it take for them to go to each place, and why did it take so long, and why is it, what barriers did they face, and also what their environment at home is like. We also went to 10 healthcare providers and asked them the same questions, but in the context of the healthcare setting. That what do you think the infrastructure of the hospital is? Do you think there should be more equipment there in order to diagnose children faster? And so once we had taken these 40 interviews, then we analyzed both the quantitative and qualitative data, interpreted it, and then came to our results. So results were very detailed, but the 3 main results were that in spite of the first 2 delays being really long, which with the median values are being shown here, the shortest delay was the last one, which means that if a child was diagnosed with TB, they got started within an average or median of 1 day or started on treatment. So which means that if the parents knew that their child had TB, they made sure that the treatment was started very quickly. It's just that coming to that diagnosis was the longest delays. If we represent both the quantitative and qualitative results together, you can see that in the orange row on the top, you can see the three delays, as I've already told you about. And then I have connected them to the qualitative delays that we found in interviews. Then what were the actual reasons that people were telling us, okay, these are the reasons our child was not diagnosed on time. So we divided them. The blue lines are the main themes, and the gray boxes are the sub-themes that fall under them. So the shape of each box shows that how it correlates to the delay on the top. So if you can see that if, for example, knowledge is a sub-theme of patient's environment, and we can basically knowledge is about TB, where to go if your child has TB, all the knowledge that a caregiver should have. And this knowledge affects the first two delays only. However, relationships within families and how close they are, how much they communicate with each other, how much of the community around them is helping them, is actually a tapering, it's affecting the last delay in a tapering way, which means it affects it less, but the first two delays are affected more by it. When I mentioned and similarly, if I go down, you can see that general physicians' involvement, 69% of caregivers said that they first went to a GP near them, but yet they were not satisfied with the care given by that GP, which I'll come to later. And one thing I need to mention is when I say PTP here, it means Provincial TB Program. It's because that program is working very closely with the TB program at Indus. And because there is friction between the two, it affects the time taken for children to be diagnosed over there. So when we come to qualitative results, we can see that there were the four sub-themes that I've already shown before. The most predominating theme was financial constraints. There was a very massive, overarching theme in all the interviews where the first thing a patient would say was, I didn't have enough money to bring my child, even though I knew my child had been sick for a long time. And we can see that, like one of the quotes as shown here says that my parents they were on daily wages, they had loans to pay, and because of all this instability, we did not have enough money to bring my sibling in before, and otherwise they could have received better treatment. Other very overarching theme that we saw was that involvement of general physicians was reported by all caregivers. And many ways they felt that the enough care or sufficient care was not provided by them. Some of the reasons are given here, that they were confused, they wanted the patient to keep coming back to them, even though they knew that they couldn't treat the patient, they wanted to keep making money from it. They were misdiagnosing with malaria and typhoid, and there were other reasons as well. And a quote that shows that over here as well is that the mother took her daughter to one doctor, and the doctor gave her several painkillers. When the child wasn't getting better, the mother took her to another doctor, and that doctor was very surprised that more tests had been done before these medicines were prescribed, and then ended up prescribing a whole bunch of new medicines to the patient without testing her again. So they just keep going from one doctor to another without much improvement. Lastly, another major the qualitative result that we found was that healthcare providers mentioned that the infrastructure of the hospital is not good enough. There is an X-ray machine, which is very important for TB diagnosis, and it keeps breaking down every few days or weeks, and because of which they have to keep sending the patients away. But if once you send a patient away, they don't really come back. So they keep losing patients that way. But one positive thing that was reported in these interviews was that patients were very happy with the way in this hospital provided them care, and they were very grateful for its existence. So as there's more research that I ended up doing that are these the actual constraints in other settings as well? And I found out that yes, and there are many systematic reviews already done where they are saying that yes, these are the major constraints. And one thing that can be done to overcome them is to go for community-based active case finding, which means that instead of waiting for the patient to fall sick and come to them, you go in the community and you actively screen those those patients for symptoms. So if you go to a house and say, do you have a few symptoms, and someone reports positive, they are more inclined to have TB than those who don't say yes to the symptoms. So one of the healthcare providers said this is very important to do because that it's like taking the hospital to the patient instead of waiting for the patient to come to the hospital. So, and the other one that the predominant factor that we found was that what do we do about these GPs? And we found out that in other countries, there are similar issues that we need to work on the GPs and somehow build this network more and their capacity more. So in other countries, similarly, in Pune in India and other settings, similar settings, this issue exists as well. So there were a few limitations to the studies. For example, patients were not able to recall exactly how long it took them to go from one provider to another. I had to help them in the interviews by saying that what was the time of the year, were there monsoons happening, were there any political issues happening in the city, and then they would kind of remember a little bit. Because the journeys sometimes were so long, it was easily like sometimes even 2 years long. And then secondly, the fact that these results are not generalizable. So you cannot, I cannot say that I know all settings have these issues because I researched only in one hospital. So this is a limitation. And thirdly, we cannot, the younger age groups were not really there because we feel that people were finding it harder to bring their younger children in, and I could not interview them because they were so sick that the parent had to leave with the child, and I could not interview them. So this is a limitation of the study. So eventually, the conclusions that we are coming to is that we need to decentralize care interventions. We cannot say that, oh, we are sitting in a tertiary care hospital and we were waiting for the patient to come to us. We have to say that we have to figure out ways where healthcare can become more accessible to people living in overburdened TB areas. And the way we can do that is perhaps take screenings to them, like AI, mobile X-ray vans, or whatever way, so that they can come closer to accessibility to TB care. And also the management of child TB through general physicians, their capacity building is very important because if we are not going to give them the trainings and the equipment to diagnose children with TB, they are not going to do it. And we have already established that by other studies. In the end, I would like to show a few photos of my participants and their children who have TB. And that's about it. Thank you. Any questions?
Yeah, let's stay on with one question.
Can I ask one question, please? Hello?
By inoculation vaccination, right? It does, but the BCG vaccine that they get when they're children doesn't last for long. So essentially, they're looking into more vaccines. There are vaccines coming out again, and they are going to start soon, but it hasn't started yet. But they have to keep doing it over a period of time. They cannot just leave it after the childhood one. Yeah.
It's a wonderful presentation.
Thank you.
For that.
Yeah.
I think can you significant improvement? My question is, in these countries, in the bulk where we have contact tracing,
Yes.
is there anything which exists in Pakistan? And I might have a second kind of component to this one. How is the interaction you said between provincial treatment program and saving this? And something else like helping.
Okay. The contact screening is very, very useful, but so far the government has been implementing that only for drug-resistant TB. So the moment there's drug-resistant TB found in anyone, their entire family is called and they are screened for it. The only problem is that there are many more cases of susceptible TB, but they are not looking into it. When we did do it, we found many more cases. So when a project comes in and they have the funding to go to people's homes and do contact screening, we have ended up finding people, but the government only takes that initiative till drug-resistant TB. So we need to kind of persuade the government a lot that this is important to do for drug susceptible as well. And because kids do not spread TB, they catch TB. So we did reverse contact screening that way, where we found TB in children and we said, someone has it in their home. So we have to do it for their families. And we did find many cases that way, but the government doesn't agree. They are like, this requires too many resources and we are not going to spend money on it. Because it does require a lot of management. Like you have to send people and you have to make sure that they come back, and they don't really even have money to come unless you incentivize them with money. Like if they will say, we are a family of 8, how will we fit into a car and come and get screened for it in the hospital unless you come to our home and do it for us? So it's very important to give those resources in that area and make sure that someone goes and screens them for X-rays at least. Take a mobile X-ray van, and we did that and it was very effective. And secondly, the provincial TB program does not like Indus Hospital. So like, because we end up finding more cases and there's a lot of rivalry between the two. So they kind of, the TB clinic is kind of orphaned. It's like stuck in the middle of the two parties, and some funding is by Indus, some funding is by PTP. So the X-ray machine, for example, is funded by the PTP. And so sometimes they don't give money for fixing it. They say fixing it should be Indus's job. So it gets stuck in the middle that way. And some people's salaries are coming from the government and some are Indus. So there's a lot of tussle, and the person working, the manager working there has really become stressed because of it.
Sarah,
Yeah.
there's a question
Yeah.
in the chat by Mr. Muhammad Akbar. What preventive measures are suggested by your hospital to the community in your study area, since prevention is better than cure?
Yeah, so this is a good question, because there is a preventive drug regimen that should be given to families, at least who have a family member sick with TB, because it's high exposure at home. And we did one study and there were very good results. It's called your isoniazid treatment, because we are giving isoniazid to their family members. But again, this was very controversial because people said that why should we give medicine to people in our family, to people who are not even sick? So even taking medicine for people who are sick is so difficult. So it was very challenging to counsel them and get people to come on board with that. But it was very effective and it was done.
Awesome, thank you so much.
Yeah.
Sarah is available during the interactive session. If you have any questions, feel free to chime in. Thank you. So we are moving to short oral presentation, and this session is chaired by Erika Shira. Erika, thank you.